Welcome, everyone, to the launch of the 2023 annual report of the Chief Public Health Officer of Canada. My name is Ian Culbert, and I am the Executive Director of the Canadian Public Health Association, and we are very pleased to be co-hosting this event with the Canadian Red Cross. While we have participants from all across Turtle Island, I am joining today's webinar as an uninvited guest on the ancestral, unceded, and unsurrendered territory of the Algonquin Anishinaabe. The increasing frequency and the severity of emergencies in Canada has prompted discussion across sectors on how best to prevent, prepare for, respond to, and recover from emergencies. Our discussion today will illustrate tangible actions that have brought health promotion into emergency management in Canada with the goal of promoting future collaborative action. Now, with no further ado, I'll invite Dr. Teresa Tam to introduce our knowledge keeper. Dr. Tam, the floor is yours.
Thank you, Ian, and bonjour à toutes et tous. It is with great pleasure that I welcome Monique Menach, our Algonquin knowledge keeper. Monique leads an Indigenous culture and media innovations organization, and she's presently a doctoral student at Carleton University in anthropology. And first of all, Monique, I'm offering you this tobacco for the opening prayer for the 2023 CPHO annual report launch today. Thank you so much for starting our event in a good way.
Thank you very much. I appreciate the offering of tobacco, and I appreciate being invited here today to conduct the land welcome and opening. First, I'd like to say to everyone, Pujashik, welcome. Welcome to unceded, unsurrendered Algonquin territory. Monique Menach Indishnikos, Kittikinik Anishinaabe and Dojuba. My name is Monique Menach, and I'm a member of the Algonquins of Barrier Lake. And, you know, when I was thinking about this report and I was thinking about the health situation in Canada, I couldn't help but think about how Indigenous people perceive health, which is in a way of balance, balancing the mental, the spiritual, the physical, and the emotional aspects of our reality, and building relationship with those around us, with our environment, and in that way, we are able to be in a place of health and well-being. And it's encouraging to me to see that this report has been done and is being launched and will move the health issues forward in Canada in a good way. So I would like to open this space with a few words to the Creator, and in doing so, making it a safe space, a sacred space, a space of learning and sharing, of recognition, of acknowledgement, and hopefully a space of friendship, a space where people feel free to say what's in their hearts and on their minds. So I'd like to say, Kachimi Gwich Jemnado. Thank you, Creator. Thank you for everything you've placed in our homelands that help human beings to live well. We acknowledge and honor the rivers, the lakes, the streams, and the oceans. We acknowledge and honor the birds, the animals, the fish, and all the good human beings. We thank you for Father Sky. We thank you for our Mother, the Earth, and all the things that live beneath the surface of the earth. We thank you for our medicines and our ceremonies. And we thank you for our ability to prepare ourselves spiritually for the spirit world, for when this short physical world ends. And we thank you for our ability to bring peace to one another, especially during times of trouble and anguish. We ask that good words are spoken here today, strong words that help us and impact us spiritually and emotionally. We remember our friends and our family who are ill, whether physically, mentally, or through addictions, and we hope they have a good day today and that they return to us soon as role models and as mentors. And we ask that you help us reach the wisdom of each of our ancestors and to bring that wisdom into that space and share it and continue to share it with our friends and our family and our communities. And we remember to live our lives with great respect for all living things. Kachimi gwich, kachimi gwich, kachimi gwich, kachimi gwich. Thank you very much. I know it's going to be a wonderful gathering today. Thank you.
Thank you so much, Monique. Really appreciate you starting us off in a good way today as I get my different cameras set up and going. So thank you so much for being with us and getting us started in a good way. As we get ready to talk about the report, I have just a minute or two to reflect on the contents of the report and how it relates very closely to work CPHA has been doing in this area when we're talking about strengthening public health systems. And I want to draw the audience's attention to some work CPHA has done, a policy brief that is available through our website, and indirectly talks about these very issues about public health needing to have a clear understanding of around our core functions, but consistency across the country so that every province and territory approaches the functions of public health in the same way. But we also need to talk about the core competencies that our workforce needs to have in place, and then the training opportunities that they need to be provided in order to gather those competencies and be able to do the incredibly complex and difficult work across the entire spectrum of public health services, but especially in the area of emergency preparedness and response. So I encourage everyone to take a look at that report and see where it mirrors Dr. Tam's 2023 report, as well as her previous reports around public health systems. So it's now my pleasure to introduce the co-host of today's webinar. As the Canadian Red Cross Vice President of Risk Reduction and Resilience Programs, Sarah Sargent leads domestic actions to address related disaster work. Disaster work that recognizes that we must understand the causal factors of risks, including inequity, to inform accessible mitigation, prevention, and adaptation actions. So, Sarah, the floor is yours.
Thank you so much, Ian, and thank you so much for inviting me here today and recognizing we're coming from coast to coast to coast from across Indigenous lands. Good morning and good afternoon. I am so happy to be here today along with Dr. Tam and the other members of this session to launch what is such an important report. This report is important to our collective work. It demands us to work together across the space of emergency management, public health, and I also believe climate change adaptation. Disasters strike at the fault lines of communities, laying bare the inequities that we know are exacerbated in times of disasters and have implications on individual and collective resilience. This is felt not only through a frame of the economic and built environment impacts, but we must also recognize and value the impacts on the psychological, physical health, sociological, as well as cultural impacts. This exemplifies why we need to remove the silos between the sciences, and this does include the social science as well as how we work alongside differing practitioners. We need to identify, understand, and recognize the conceptual synergies that bridge our work. This will help to find a common vision on how our agendas come together, because I really think that's at the heart of this report. It's about how do we recognize our distinct work, but then also pull it back to that common agenda. And in order to do that, we need to go beyond the communities of practice. We really need to recognize the people that are at the center. Given this, their voice is integral to defining sustainable and localized solutions. And by applying an inclusive lens, we action the ask, and the ask made to us is nothing for us without us. And this demands genuine participation. Genuine participation aims at including voice, but also the diverse forms of knowledge and redressing power relationships. Within this report, it speaks to the work of the Canadian Red Cross in the application of a tool called the Enhanced Vulnerable Capacity Assessment Tool. And what this does, it really helps us look at how do we work in relationship that is both contextually and culturally appropriate. At the heart of the EVCA is the participatory approach of engaging communities, and as well as those key stakeholders, to better understand current and emerging risk factors, their underlying causes, and how to recognize the assets and actions that can help to reduce the impact of those risks. These tools include and recognize that we must also consider the impact of climate change. We must also consider gender and diversity, as well as public health. And in order for it to work, we need to also understand how does its application work and apply in different scenarios, including working in urban, remote, and northern communities. The EVCA is a useful tool for resilience work because it serves as an entry point to work alongside community and to provide a holistic risk landscape. Communities understanding their holistic risk landscape are then able to identify and work alongside strategic partnerships and within community and their members to define sustainable solutions. These solutions are, just like disasters themselves, are sometimes very complex, and complexity means whole of society. It means recognizing the contribution of multi-sectoral approaches. And that is also how I started, and it's the recognition of the space of emergency management, the space of public health, and the space of climate change adaptation to come together. And I believe that's what makes today so exciting, because on this call today, I'm looking down and I see 631 participants. We're coming from different backgrounds, different areas of expertise. But I do know that we have public health experts, we have emergency management experts, we have also climate change adaptation experts. And together we can embark on a much needed discussion about the cross-section between our space. And to do this, I'd like to start with introducing the key presenters. Dr. Theresa Tam, who was named Canada's Public Chief Health Officer in June 2017. At the federal government's lead for public health professionals, she provides guidance to help protect the people of Canada against health threats, advance health equity, and promote healthier communities using the best available data and evidence. And I think today she's going to talk about what that best available data looks like and how we can strive for being even better. Dr. Tam is a pediatric infectious disease specialist with expertise in immunization, emergency preparedness, and global health security. Nikki Legg is the Director of Mental Health and Addictions from the Newfoundland Department of Health and Community Services. She has a master's in social work and over 20 years experience working in the health sector, both at the community and government level. As the Provincial Director for Mental Health and Addictions, Nikki is responsible for the implementation of the Towards Recovery, a mental health and addictions action plan for Newfoundland and Labrador. Mattia Alatini is the Chief Strategist for GSD Strategies. She served 2 terms as the Chief of Kluane First Nation in bringing her expertise and energy to her work regarding Canada's Indigenous self-governments and Northern communities. She was instrumental in leading the territory in the development of the community-based testing, as well as First Nations-led wastewater surveillance during the COVID-19 pandemic. And now it is with pleasure to hand over to Dr. Tam, who will present on the CPHO vision for integrating health promotion principles and approaches within emergency management. Dr. Tam.
Thank you so much, Sarah, for that introduction. It's great to see everyone, and I see 645 participants now who have joined, and I want to thank all of you for the tireless work that you've been doing for your communities. I would like to acknowledge that Canada is the homeland of First Nations, Inuit and Métis peoples, and that I am joining you from Ottawa on the unceded traditional territory of the Algonquin and Anishinaabe people. And before I begin, I want to also thank the CPHO reports team, our report advisors, those from my office who've been working with CPHA, the Canadian Red Cross, and others for our engagements and communications teams. So as the preceding introductions from the chairs they've said that, you know, emergencies are really becoming much more frequent, and they're complicated as well in terms of their impact and management. So I think we've seen firsthand how emergencies are really part of our daily lives now, both here in Canada and around the world. Les urgences font de plus en plus partie de notre quotidien, tant au Canada que dans le reste du monde. Our communities have faced monumental challenges in recent years, from the scale and scope of this COVID-19 pandemic to the more frequent extreme weather events driven by climate change, and this year, unprecedented wildfire season that has affected the quality of the air that we breathe and forced evacuation of thousands of people. These events can have profound impacts on our mental, but also physical health. They have social and economic impacts, and they exacerbate health inequities. Emergencies can occur simultaneously, and recovery from one emergency may not be possible before another one hits. It's very clear, looking back at our pandemic and other emergency response, that the impact of emergencies are not the same for everyone. Whether and to what degree an emergency impacts individuals and communities is influenced by how likely they're exposed to a hazard, by geographic location or your occupation, for example, or your living conditions, but also the intersecting inequities or vulnerabilities that communities experience, shaped by these determinants of health that you see on this slide. And of course, is determined by the resources that communities have access to for them to respond and recover. So fundamentally, it is about differential assets and strengths of communities and the ability to access services. This is why an equity-centered approach to emergency management that focuses on community is absolutely critical. Also essential is our need to support the inherent right to self-determined decision-making of First Nations, Inuit, and Métis communities as it relates to emergency management, which is in keeping with Canada's action plan to achieve the objectives of UNDRIP, the United Nations Declaration on the Rights of Indigenous Peoples. Vital to the success in our response to any emergency is trust, social cohesion, and critical community action. After all, we saw in the pandemic that it is vaccinations and not vaccines that save lives. So this year I gave a lot of thought to how public health can work with communities and partners across sectors to build healthier and more resilient communities before an emergency occurs, and better tailor our supports for population and communities experiencing greater impacts during a response. So both upstream and downstream actions. We need to invest in our social infrastructure. These social infrastructures is as important as investing in physical infrastructure, such as building a dam, so that when communities are more resilient, we're better equipped to prevent, withstand, and recover from emergencies. The good news is that this is already happening. There's a growing focus on community resilience as part of emergency management efforts. And as the public health sector, we have an important role to play together with emergency management and other sectors to bring our existing knowledge, expertise, and tools to support our collective work. So I thought that one way of ensuring that we can systematically build in community resilience and equity in the whole emergency management continuum is to leverage the core or essential public health function of health promotion. Why is that? Well, health promotion is the process of enabling people to increase control over and to improve their health, so that improving the conditions in which we live, play, learn, work, and age, and working across different sectors, we create more community resiliency. Health promotion programs promote health by providing ways to work with communities and partners to advance health equity, strengthen social supports, and build trusted relationships that can foster that social cohesion. Health promotion can complement indigenous knowledges, as our knowledge keeper just said in her opening remarks, that it is about a balance. This is about focusing on the interconnectedness of physical, emotional, mental, environmental, and spiritual well-being. The same approach extends to social emergencies and public health crises like the toxic drug crisis that we have happening all across the country. In the report, there are many case studies and examples, and also a list of tools in the back that includes, for example, the EVCA, the Enhanced Vulnerability and Capacity Assessments, and I encourage you to take a look at those to see if they're helpful. In the way forward, I highlighted the 3 priority areas that guide public health and emergency management practitioners to work together, break down those silos in order to make systems level change. First area of action is prioritizing community resilience across the whole EM continuum, from mitigation, prevention, all the way to response and recovery. This means partnering meaningfully with communities to integrate local knowledge, understand their social infrastructure and support systems, and how to strengthen them. So investing in relationship, and because ahead of time, because trust building takes time. And it also involves exploring how First Nations, Indigenous, and Métis knowledges and practices can inform mitigation initiatives, such as in climate change. We must understand both the needs and the capabilities. And as one of my colleagues, Dr. Gaynor Watson-Creed said, well, you got to ask about strengths, but also what during an emergency can this community not live without? For example, persons who use drugs cannot do without the provision for harm reduction or drugs that they need access to, for example, even during a hurricane. So one other way is to work with community partners to develop community indicators of resilience that support community processes and assets. For transformative action, though, we require ongoing resources that are coordinated, easier to access, and enable full participation of communities in emergency efforts. One of the things that we thought about internally to the federal government is simplifying and streamlining funding mechanisms across sectors. We need to support dedicated and sustainable funding for Indigenous-led, community-based emergency management. So the second area of focus is how do we systematically integrate health promotion and these public health principles into emergency management policies, plans, and procedures, and training our workforce at all levels. And some of the ideas include including health promotion professionals at the emergency management decision-making tables who can help apply equity and community-oriented tools to our plans, risk evaluations, guidance, and etc. We could develop and implement governance and accountability structures to engage communities as ongoing partners. And you'll hear an example of one of these later on from Newfoundland. We also need to enable First Nations, Inuit, Métis communities to the right to self-determination as it relates to emergency in their communities. Nous devons appuyer le droit inhérent de l'autodétermination des communautés de Premières Nations, des Inuits et des Métis en matière de sécurité civile. Supporting research is really important on how do we bring these public health and health promotion approaches and tools into emergency management. Last but not least, the area of focus that we can all put is to embed equity in emergency management science, evidence, and technology. I think we've heard over and over again that we need to have integrated and timely surveillance systems that can provide this aggregate data needed to tailor our response to the needs of different communities. You will hear an example from the Yukon on how communities are empowered to act by having data later on. We need equitable access to this credible information to inform decisions. So considering the digital environment that we all live in, the infodemics and the massive mis and disinformation environment is that we need everyone to have access to credible information. Research is massively needed, as I've said, to build effective health promotion approaches and tools into emergency management. And to support this, I'm really happy to say that the Office of the Chief Science Officer, Dr. Sarah Viebeck in the Public Health Agency, has developed a companion resource called Generating Knowledge for a Health Promotion Approach to Emergencies, which will be published outlining the priority knowledge gaps and research needs for this year's report topic. And I'm really, really happy that the Canadian Institute for Health Research, CIHR, is going to also launch a Catalyst grant opportunities shortly after this report launch. So without further ado, I'm just going to close this opening presentation and hand the mic back to our chairs.
Thank you so much, Dr. Tam. I'm actually going to hand it over to Nikki Legg, who will be presenting.
Thank you, Sarah. And thank you, Dr. Tam, for inviting me to participate today on behalf of the Provincial Government of Newfoundland and Labrador. So when the Government of Newfoundland and Labrador established its Emergency Operating Centre, it was clear that some communities and populations may be more vulnerable or disproportionately impacted by the pandemic. So in March of 2020, a Vulnerable Populations Task Group was mobilized as part of the Emergency Operating Centre for the COVID-19 response. I chair this task group on behalf of the Department of Health and Community Services and the 60+ members of that task group, whose membership included community agencies, regional health authority staff, Indigenous organizations and communities, government departments, advisory councils, and including people with lived and living experience. So in addition to the task group, there were 13 working groups that were formed, which were co-chaired by government officials as well as various community agencies, in total representing hundreds of individuals and broad networks. These working groups reported into the Vulnerable Populations Task Group on key issues impacting communities on the following topics: opioid dependence and substance use treatment, housing and homelessness, health and justice, access to primary care, rural, remote, and Indigenous health, newcomers to Canada, food security, seniors, gender-based needs, persons with disabilities, children, youth, and families, income support, and mental health and overall well-being. So the task group's purpose was to anticipate, assess, address issues facing specific communities and populations during the pandemic. Easy mandate, hardly, but it was very, very positive experience. And as chair, I had a seat at the Emergency Operating Centre where I could directly bring forward concerns and issues needing attention by the task group. I could also listen in to the overall emergency response planned by public health with a population health lens and share knowledge that I was learning from the Vulnerable Population Task Group, some of which was new information for me. At the height of the pandemic, the task group met 2 to 3 times a week for several hours, and the 13 working groups also met in addition to those meetings. Key issues for the Emergency Operating Centre were brought forward, and public health officials often attended our meetings at the Vulnerable Population Task Group to provide us status updates on the latest guidance or seek the task group members' input in real time on various issues. This structure really removes silos and hierarchies. We were all partners in this approach, and it was very inspiring, rewarding, despite the urgency and pressures, we were all under. Community sector leaders provided public health officials with insights on disproportionate impacts on the population and educated us all on systemic and structural inequalities that were already present prior to the pandemic, but were now amplified. Public health officials contributed by improving understanding of epidemiological information and were able to adapt public health measures to reflect the needs of these populations. There are many successes of the Vulnerable Populations Task Group that I'm happy to report. Here are a few. For example, there was an establishment of a provincial food security helpline, which streamlined food requests and the redistribution of food supply provincially. There was a development of a low barrier shelter and alternate housing plan for individuals experiencing homelessness with the COVID-19 symptoms. We launched a provincial opiate dependence treatment phone line and enhanced services for people with substance use disorder, including take-home carries. We established a harm reduction mobile team who brought COVID vaccine and harm reduction supplies from primary care to individuals living on the streets and in shelters. There was increased access to virtual care options for mental health and well-being through bridgethegap.ca. There was an establishment of domestic helpline. Income testing for individuals working in the sex trade was waived so they could avail of income supports. Public health guidance was translated in over 10 different languages in our province, which is a first. And the delivery of personal protective equipment and technology devices such as laptops, tablets, and phones to support vulnerable populations were efficiently delivered by our community partners. So since 2020, we've had 2 evaluations conducted for our work under the Vulnerable Populations Task Group. Results reflected a really strong desire to maintain this task group structure and to address other public health emergencies and systemic issues present prior to the pandemic. To put it in perspective, a task group member was quoted as saying, "This task group is a place for people who care about people. We want to do more of that." So since COVID, the task group and associated working groups continue to meet and have assisted with emergency response for Hurricane Fiona and the wildfires in central Newfoundland. But I think what's more interesting is that the task group's keen interest in consulting, reviewing, and providing feedback on provincial policies, action plans, and strategies is really where the group continues their efforts. They've already done so in a couple of instances, such as consultation on a draft provincial social, economic, and well-being plan. And they also reviewed and provided guidance on the approved gender responsive standards of practice for mental health and addiction services developed by our department. So in summary, the Vulnerable Populations Task Group model is well positioned to become a more formal component of the provincial emergency preparedness and response structure, but it also represents a successful example of sectoral, community, and public health collaboration that can be scoped and scaled to address other public health priorities, including building healthy public policies and addressing structural inequities to foster and grow resilience.
Thank you so much, Nikki. And listening and your starting place of talking about task force and 60 groups and 13 working groups. And I think many of us in this virtual space have participated in such events, which might not necessarily have reaped the rewards that yours has. And within that frame, recognizing, I think, to Dr. Tam's words about how it has to come from a place of trust. And from a place of trust, you build relationships, which lead to sustainability. And I think I heard examples of that throughout your presentation. If you wouldn't mind though, I mean, recognizing that lessons aren't always learned, but I think you have been able to apply lessons. What have been some of the critical points that led to your success? And maybe if you have time to think about what might have been some of the barriers that you really needed to overcome.
Right. Well, I think a key factor of our success is having broad representation around the table. So it wasn't just government departments trying to trouble solve an issue. We had individuals from health authorities, community agencies, and also a lot of individuals who had lived in living experience, whether it was persons with disabilities, seniors, individuals with mental illness who knew firsthand how to, what a particular issue, how it might impact a population or community. And so having all those players around the table at the one time was really eye-opening. And from a government perspective, to hear some policies and how you intended for a healthy public policy to serve the population a certain way, but some of the unintended consequences or impacts, or how our situation was evolving during the pandemic when things were shutting down, how simple policies around when you would access a grocery store would impact people differently. So it was really eye-opening. And I think the secret success to that was having everybody around the table and having those trusting relationships, that everybody's voice was important. I think another key success was that it probably wouldn't have been such a success if we didn't have a seat at the EOC. So being able to go to the EOC, voice concerns and challenges that the Vulnerable Population Task Group were bringing forward, and then bring back answers and solutions to that group, and to share that knowledge 2 different ways, both to the task group and to the EOC and public health officials, was really important. From a challenge perspective common barriers, I don't think everybody probably understood, and ourselves too, the value that this structure would have. We were just trying to fit the need. We knew that some people would be left behind, or, there would be some challenges. And we had we called Snowmageddon a couple of months prior to the pandemic. And so it kind of prepped us for some of the challenges we would have in the addictions field. So I think as a social worker, that's my background, I think I had some strong facilitation skills to bring to the table. And we had some lessons learned from the substance use world. But the impacts of the pandemic were very far-reaching, and I don't think everybody understood the value of this group in the beginning, but that quickly changed as we were able to provide more information. And so there may have been some meetings that we might have been left out in the beginning in the busyness of it all and trying to understand everybody's place. But I think it's very clear now, crystal clear, that this task group had an incredible value to bring to the table to support populations. And if I could just add one more thing, I think communication, we prepare a specific guidance or piece of information, whether it was hand washing or what have you, and how that would be communicated to other populations, whether it's our Indigenous populations or the disability community, or people who are living on the streets. All of that had to be taken into account. And so one of the key things that we had to overcome was, how do we communicate to these vulnerable populations and communities? And so we took that very seriously. And every one of those 13 working groups would take a piece of guidance or information from public health and rewrite it and send back to the Emergency Operating Center with new insights and information on how to communicate effectively and get the message out. So I think that was something we learned and we did together. It was a challenge that we overcame.
And I think if we leave with something, those of us that work in the emergency management world, the requirement to have those connect points into the emergency operating center is integral and key. So I appreciate your words. I'd like to now turn it over to Mattia Alatini, who will speak to us as well.
Thank you so much. Thank you for the invite to participate and share our experience here in the Yukon. So Danjay, ING Mathia Ye, Thuan Mankai J. I am a member of Kelowna First Nation, and I had the honor of working with the 14 Yukon First Nations in Yukon throughout the pandemic, and working as a COVID coordinator and really finding out.
Okay, we were a bit concerned that we might lose Matea. Oh, but she has just rejoined.
I'm back. I'm on my cell phone and I'm hoping this works. I'm going to switch locations. I had the opportunity of being that COVID coordinator, or being the advocacy voice for Yukon First Nations, 11 of which hold modern treaties. And that makes a significant difference when we look at what occurred. So one of the biggest lessons learned throughout the pandemic was the ability to empower communities will actually transform how communities respond to any emergencies. And the fact that we were in a modern treaty context allows us to really focus on a government to government or nation to nation framework. So that looks a little bit different when it comes to access to funding, because we were able to receive funding directly from the federal government for emergency response, which was a game changer when it came to how communities could respond. It allowed for autonomous decision-making on what we needed to keep communities safe. And that in itself really speaks to what we heard from our previous speaker, Nikki. You guys did an amazing job. We looked to you guys all the time for best practices. And that piece about bringing the voices to the table. So just having the access to funding, the autonomous decision-making, that created equity. that created a seat at the table. So we were able to advocate for our ability to implement rapid testing. So throughout the pandemic, we had one of the biggest shifts that occurred was when we implemented rapid testing for our communities. We had at the time about an 8-day turnaround, 8 to 10 day turnaround for individuals in communities to get tested. And that wasn't working for communities. You have small populations that are caring for elders or caring for other family members, and you can't be isolated for 8 to 10 days. So the implementation of rapid tests was a game changer when it came to community health. Just that one technology that we didn't have access to prior to developing a relationship or a partnership with the National Microbiology Lab, that really changed the trajectory of our communities. We were able to actually implement measures that saved lives, and the individuals that went and taught other people in community how to access or utilize the tests were community champions, and they were looked to as experts in taking care of community. Just that one tool or one technology actually had a profound impact on our small communities. We know that our Indigenous communities are disproportionately affected. So those types of mechanisms or those types of technologies are game changers when it comes to saving lives in our nations. The other technology that came out of the pandemic that we've actually implemented and have been operationalizing for just over a year, maybe a year and a half, is wastewater technology. And that was also formed out of that partnership with the National Microbiology Lab. We were able to implement wastewater and detect as a first line of detection, whether COVID, flu, or RSV was in our wastewater. And that advanced knowledge, so using the wastewater and using a gene expert device in the community to detect right away whether there are spikes in infectious disease in community or infectious transmissions in community, has actually empowered communities to really stay safe. There's been a mind shift in how communities can take care of themselves in community in the Yukon. We had an opportunity to really focus on what are the factors of transmission? How do we keep community safe? And when we saw any spikes in community, one community in particular, Champagne and Ajax First Nation, they were able to take that information and provide advisories to their nation, their community. And they were able to also put into measures into their office so that it reduced transmission. We see the power of wastewater as not just for the COVID, flu, RSV, but also for the SOPAs, so the substances of potential abuse. There is an option or an opportunity to do surveillance or monitoring for those substances. And it also is an opportunity to look for some of those things such as polio or tuberculosis or other diseases that we know will disproportionately affect our First Nation communities. So throughout all of that, we were really reflecting and going, how can we take this and continue to enhance the success of partnerships, enhance the success of equity that we saw during the pandemic? And really one of those big pieces, and I was really glad to hear about the CIHR supplemental report and or their additional funding, because that access to funding, whether it is through INAC or ISK or the fact that tri-council funding is not, First Nations are not eligible for tri-council funding. So there's some barriers there. How do we remove some of those soft barriers so that First Nations can have access to the direct types of funding that will allow for autonomy and for equity and for that voice at the table? The other barrier, or the other kind of key element that we saw that was really the underlying reason for our success was the partnership with the National Microbiology Lab. So the partnership from federal departments at a nation-to-nation level is game-changing for First Nation communities. That support, that technical expertise is something that we value so much, and it has created the well-being in our community, because we know that we've broadened our network, we've broadened our areas of expertise, and we have somebody, they got our back. So that's huge. The other barrier that we're continuing to work on is policy shift. How do we look at some of the policies that are systemically racist? How do we change some of those policies that do not allow for First Nation or community voices to be at the table? And how do we shift that? So that really is our focus over the next year or two. And the other piece, when you look at this pandemic, made it so apparent, is access to data is what saves lives, and communicating that. I really appreciated, Nikki, when you were talking about the communications, because that is really the key to saving people's lives, is having the message go out in a way that people can hear. So meeting people where they're at. How can we communicate the urgency or the importance of information? We have to have access to data. And right now in the Yukon, the First Nation communities do not have access to data. We end up as One Yukon Coalition or Yukon First Nation COVID response, we were the ones that kept our own data and ended up sharing that as, in order to save community, in order to save lives. These are our elders, and it's too important. So the siloed approach is no longer going to be working. And I think that we need to take that shift to a community-centered approach to deal with the toxic drug crisis that we have right now. And this is not just in the Yukon, I think this is across Canada. And the North right now, we have a syphilis outbreak. Like, communication is so key to that, but it is about breaking down those silos. So I think that's it for me. Thank you.
Thank you so much. And as you were speaking, I was taking notes, and I really appreciated the way you spoke to what were those foundational pieces that enabled you to be successful, and how you spoke to the genuine, autonomy on decision making, empowering communities, recognizing nation to nation, having a seat at the table, as well as the space to advocate. And on that, recognizing as well what will impact sustainability of some of these efforts. And you spoke to some of those barriers and challenges, one of them being access to funding, and the second really about that policy shift. So often participation in policy and sitting at different roundtables can sometimes be seen as disingenuous. And so from your perspective, how do we make sure that it is meaningful participation, it's active participation in the policy conversations, so that we are really shifting the way we work and define policy that's going to have the right impact for the populations it's meant to serve?
I think it's just having people having them have a seat at the table is number one, but actually listening to what they're saying and implementing, because that disingenuous piece of the relationship is always when you go, oh yes, we're very much interested, but then there's no shift or no change in anything. And communities, anybody knows when that occurs. You can see it in any relationship. So really, when we look at reconciliation in Canada, when we look at the inclusion of Indigenous voices and try to address the inequities, it is about trying to understand a different way of thinking, a different way of being. When we're talking about why Newfoundland and Labrador had such success, because they were able to listen to different voices and implement the knowledge that came from those different voices. And that is exactly what the rest of Canada needs to do in order to shift and in order to reconcile the inequity we see. I think there's an opportunity here for us to lead the way in how we shift from the traditional hierarchical, patriarchal society that we are. Like, we are a Western society, that's our construct. But how do we shift to a more holistic and traditionally Indigenous way of thinking, where women's voices are valued at the table and they have an equal seat? And Indigenous communities, women's voices are a little bit louder than men's. So, I don't know if that's equity. There's a real opportunity for us to be leaders internationally if we allow for that Indigenous voice, that holistic perspective, to be incorporated into our society and into our ways of governing.
So well said. And may this be a call to action to actually take action against that shift. I think all of us appreciate that message. Ian.
Thank you.
Thank you so much, Sarah, and thank you to all of our panelists. That was a great conversation. And now we're going to turn to our questions from the audience. So I'll invite all of our participants to turn their cameras back on. And let's turn to one of the first questions from Christine from Nikki. And she's asking about the food security phone line. And she's wondering if you can provide a bit of details about how it was organized. For example, how was it staffed? How did community members learn about it, get assessed for need, and how was food distributed and what types of food? So basically, give us the entire program in 30 seconds or less.
Oh, I wish my co-chair for that working group was here. No, in all seriousness, we had some community partners. We had a lot of food banks, a lot of communities who were supporting food distribution and food banks, but we didn't have a 1-800 number. And so we actually started by using our provincial health line. It was the quickest thing that we could get off the ground. So we used our 811 phone line as kind of the redirect to which moved then to our Food First NL service, which is a community agency. And then they helped support the further distribution of requests across the province. But they also did so much more that I'm sure I'm going to miss, the contributions that they made in such an incredible way. I mean, even foods from our school food sharing program, they were able to leverage and redistribute to communities. So they did so much incredible work, and then also did the organization that needed to occur. So using 811 as kind of a triage point, then to Food First NL, and then out to all the community banks and efforts that were taking place. So that's kind of the structure that we used, but there was so much detail and so much work that was led there by both the Department of Health and Community Services, who co-chaired it with Food First NL in our province. And they should be commended for all the incredible work that they did.
Excellent. Thank you so much, Nikki. Now I'll turn to Matea. There's a question from Rebecca. She says she was moved by your statement that access to data saves lives, which I think we can all agree with. But she wonders if you can provide specific examples in your community. You mentioned elders, where this was applied.
Right away, it's the when we had spikes in cases, there was a lot of discussion at the decision-making tables about whether we should be making that public or not. because we didn't want to stigmatize a community. The flip side of stigmatizing community is you could have massive spread in a very small population if you do not share those numbers. So we had to advocate for numbers to be shared in an aggregate kind of regional way immediately, so that we could create some sense of urgency for people to implement mask use, or just for them to know that they need to take extra precautions because there is spikes in cases in their community. And in a lot of instances, communities already knew, because moccasin telegraph goes really fast, and usually community can tell us before anything else, before we get case counts about spikes in cases. So I think just that the fact that we as Yukon First Nation COVID response also had access to positive cases out of the rapid tests made a big difference for just that ability to communicate risk to community.
Excellent. Thank you so much for that. So before asking Dr. Tam to give some closing words, I just wanted to bring to people's attention, it was noted in the Q&A, but Dr. Howard New, Deputy Chief Public Health Officer, will be presenting the 2023 report en français at a side event hosted in collaboration with la Journée annuelle de santé publique on the 28th of November in Quebec City, and work is being done to see if that event can be recorded or otherwise broadcast to those who will not be in Quebec City. So with that, it is my pleasure to turn the microphone back to Dr. Tam for some closing words.
And thank you so much, Ian, and our presenters. I was so inspired by those two presentations. And Matea and Nikki, thank you so much. And I was really encouraged, actually, by what you're saying, and that there are paths and concrete actions that we can take to break down silos and really provide a fundamental shift in the way that we look at emergency management, which was what I wanted my report to be about. I think we can all agree that, you know, the vital ingredients to really respond to, manage, prevent our next sets of emergency, which are inevitable, is a strong public health system. Ian talked about the CPHA work, and I've been working in this area as well. And it's I think, really important to keep at it, because there's much that needs to be strengthened in the whole health ecosystem, but a strong public health system and resilient communities are absolutely vital, I think, to our path forwards. And to take a fundamental shift in the way that we look at emergency management, first of all, is having a seat at the table for public health, but bringing the voices of the communities, of the different populations, people with different needs, to that table, listening and implementing and providing a more holistic and equitable way of managing emergencies. I think breaking silos, a lot of our speakers mentioned, and it's between sectors, emergency management, public health, many other sectors that have a role to play in our structural and systemic inequities, but also breaking down communities of practices, even within public health, between scientific disciplines. We heard that knowledge sharing is power sharing. Access to data is vital, and knowledge empowers communities, one technology or tool at a time. So there are concrete ways that we can do that. And of course, looking at many different ways to access resources and reduce policy barriers in order to address racism, the effects of colonization, and many other inequities. Just want to point out that, of course, when I was talking to funders of, say, research grants, there's not a lot of research funding that addresses these intersectionalities. And so I hope that the CIHR Catalyst grant will be at least what it should be, a catalyst to stimulate more need to address these gaps. I heard about the need for communities to have at least a bit of resources that preferably is sustained over time in order to address emergencies. And there are quite a number of federal funding programs to try and do some of that. I know that during the pandemic, for example, a lot of these were stood up, like the Immunization Partnership Fund, that enabled communities, different communities, to increase vaccine confidence and have people roll up their sleeves. Health Adapt is a Health Canada program that provides some funding to communities to begin these intersectoral tables and support some of your work. But I'm sure none of this is enough. So I think collectively at every level, I think people ask, well, at what level do we need these intersectoral tables, but also need these community tables? I would suggest is really at every level, and every level we can break down different types of barriers. So I am inspired by this session. I hope that you are too, and that the report enables you to open some doors in your advocacy at different levels in order to increase community resiliency and reduce inequities in how we manage emergencies. So merci beaucoup à tous, and I hope that some of you can join Dr. New at the Journée annuelle de santé publique.
Thank you so much, Dr. Tam. Thank you, Mattia, Nikki, and Sarah for a great session today. As mentioned in the chat, today's session was recorded and will be posted to CPHA's YouTube channel momentarily. And everyone who registered to participate today will receive a notification when that recording becomes available. So have a great day and keep up the good work, everyone. Take care of yourselves and be kind to each other. Goodbye.